So again, welcome to the Addiction Treatment Starts Here program. This is the first peer session for the Substance Use Disorder Counselor Peer Forum. Joining us today will be Dominique McDowell, who's the Director of Substance Abuse and Homelessness Services at Marin City Health and Wellness Center, as well as Danny Contreras from Health Services, who's a Health Services Manager at Santa Cruz Health Services Agency. Together, they will share insights about harm reduction in challenging patients, including reviewing interventions on high-risk behaviors, interventional conversations with patients, as well as contingency management questions. Finally, we will take the last 5 minutes of today's session for me to wrap up with releasing a few poll questions, sharing a few reminders, and as well as making some closing remarks. And before I pass it on to Danny and Dominique, again, please mute yourselves so we can hear our guest speakers. So I'll now turn it over to Danny and Dominique. Thank you.
Good morning, everybody. Dom, I don't know if you want to jump in and say hello too real quick.
Good morning all. Glad to see you all. Let's get it done this morning.
All right.
Have fun.
Yes. Okay, so we wanted to start off with just doing a check-in. What clinic, tell us what clinic you're from, and then tell us what your understanding of harm reduction is. And if we can go around, I think I seen there was about 18 people, 20 people now. It's climbing in the chat. So I'll start first. My name is Danny Contreras. I'm with the County of Santa Cruz Health Service Agency, and I'm going to hold on my understanding of harm reduction, and then we'll go around. So whoever wants to go next. Maybe I should call on somebody. Aaron.
I'll go. Oh, okay. My name is Dwayne O'Bear. I work at Family Health Centers of San Diego, and harm reduction is meeting the client where they are and moving at their pace with their goals.
Okay. I see Susan from El Dorado County, El Dorado Community Health Center. Harm reduction is meeting people where they are, if they're still using or if they're ready to quit. Thank you, Susan. Thank you, Susan. Anybody else want to put anything in the chat? It's okay to speak to us.
Good morning, everyone. Now there's too many people. My name's Eve. I am a community healthcare worker. I work in the Russian River area, live in Santa Rosa, California. And my understanding of harm reduction is reducing the risk of things that can happen when you are using, doing risky things. If it's sex or drugs or just and educating how to reduce the risk of disease.
Good morning. My name is Cornelius Thompson, and I'm a community health worker here at Lomita Family Medicine Clinic in Harbor City, California. And my understanding of harm reduction is reducing the risk of risky behavior. Taking one day at a time and meeting them where they are.
Exactly. Thank you, Mr. Thompson.
Good morning. My name is Brenda Lukin Diaz. I'm the Associate Director of Youth Outpatient here with Valley Health Associates. And everybody took my answers, but it's understanding of reducing the high risk behavior and meeting the youth where, well, since I work with youth, meeting the youth where they're at, and finding strategies that also work with them and not against them.
Thank you. Thank you. Let me see. So I must inform you all, working with me and Danny, we're very interactive type of guys. So we will call your name. So Miss Yvette Ariola. Yvette.
Hey guys, Yvette's audio is having some issues.
Okay.
Right now.
Glenna, Miss Glenna Edie, Adventist Health. Miss Hammer. Okay, Brenda. Just said harm reduction. I agree. Meeting where they are and begin to reduce harm reduction. Okay. All right.
Good morning, guys. Sorry, my audio is having problems too, but I did put it in the chat. So Elvia from Adventist Health Hanford in the Central Valley. And like everyone else said, is yes, meeting the patient where they are at, and if they're going to continue to use, show them proper or safer ways to use, right? So it causes less harm.
Who else? What about Roy Ball? No response there. Clayton.
Hi, good afternoon, everyone. My name is Clayton. I'm from Southland Integrated Services over in Garden Grove. And what harm reduction means to me is also meeting the patient where they're at, as well as minimizing or reducing the like social or physical consequences from like the actions or the actions that you do.
Thank you.
Lizette?
I think Lizette went.
Lizette went?
I think so. Oh, no.
Lizette is also having some audio issues. I'll see if we can get that fixed.
Okay.
Lorraine, did she go?
Hi, everyone. Good morning. My name is Lorraine Trejo with Family Health Centers of San Diego. And pretty much like everyone else has said, it's reducing, helping them reduce their risky behaviors and also their substance use that impacts all areas of their life, meeting them where they're at. Thank you.
Thank you. Anybody else that hasn't gone? Margarita.
Hello. My name is Margarita and I'm with Salud para la Gente. My understanding of harm reduction is, meeting patients where they're at and making sure they're safe during their use as well.
Okay.
Good morning. My name is Aaron Moore. I'm from Family Health Centers of San Diego. Just like everybody said, it's meeting the clients where they're at, giving them information, resources, and skills to use safer if they're going to continue to use, and to help avoid overdose and disease.
Thank you. Yvette put in the chat, I'm from Southland Integrated Services. Harm reduction to me is getting to reduce harmful behaviors and prioritize a person's safety. Sorry, everyone, I'm having audio issues. I'm not sure if we covered everybody.
Can you hear me? I'm Christopher from Roybal Clinic. Can you hear me?
Yes, we can hear you.
Hi, I'm the substance use disorder counselor here at Edward Roybal Comprehensive Health Center. Harm reduction is it's also evidence-based, and it's also a client self-centered approach, and it seeks to reduce the health and social harms that are associated with addiction and substance abuse. And like everybody else said, meeting the patient where they're at and trying to, whatever drug they're using, trying to reduce the use.
Thank you.
Danny, can I read something real quick before you start the slides?
Yep.
I'm gonna share something with the group. Harm reduction is a phrase. Let me read something to you guys. Harm reduction arose from multiple movements in the United States in the 60s, 70s, and 80s, including the Black Panther Party survival programs, the women's health movement that emerged from feminist activism around reproductive health, and grassroots activism during the AIDS crisis. From these movements, advocates and activists created a vision and practice of harm reduction that continues to challenge our perspectives about people who use drugs and people's rights. So I just want to give you all the information in case people, because a lot of us get into harm reduction and it's just something that it's a practice that comes along with working in this field sometimes, but sometimes we need to know the gist of it, where it comes from and why it came and what it was about. So I just wanted to share that with you guys before Danny move on with the slides. Thank you.
Thank you, Dom. Juan, you want to go to the next slide? Okay, we put interventions on high-risk behaviors, having the difficult conversations, focus on motivational interviewing tools, exploring ambulance, identifying stage of change, open-ended questions, listening and validation, focus on principles of harm reduction, focus on respecting and supporting patients autonomy, understand that not all providers have the skill set and time for these interventional discussions, and understand that the SUD case manager can support the therapeutic provider patient alliance. So, we sent a survey out, and I think we got a lot of different answers of where people were at on where they're at their clinic or their site. And, I know as working as the county of Santa Cruz, when I first started here, a lot of the providers were not on board with MAT. Matter of fact, we had 2 providers. One was actively prescribing, and he basically inherited a bunch of legacy patients that were on Suboxone. And then the other one was not, but was more of a backup. And so fast forward 5 years later, we went from 1 to actively prescribing to about almost 30 ex-waiver prescribers. And not all of them are actively prescribing, but there's a good chunk of them. I would say at least 15 to 20. And not all of them have a really big load. But some of them don't, like it says right here, they don't have the skill set, or they're just learning this stuff as we're going. And so, like, for the case manager, for the drug and alcohol counselor, for the peer support specialist, for the community health worker, sometimes you're that linkage, and you're going to have those difficult conversations, not only with the patients, but with the provider sometimes, and I think that's a crucial piece of it, because getting your providers on board or talking to them, but also you having to have those conversations with the patients, that the providers are not ready to have. And so that's where we all come in, is to be able to have that. I don't know, Dom, if you want to say something on that. You good? Okay, so next, I think we wanted to do a case review. So if I could get somebody to volunteer to read that, and then everybody kind of dissect. I put some questions in there, but those are not the only questions. Like, if you come up with something, then bring it up, and we just kind of want to kind of dissect this together as a group. Not so much me and Dom, but everybody as a group. You got any volunteer want to read it?
I'll read it. I'm Susan. I'm with El Dorado Community Health Center up in El Dorado County.
Thank you, Susan.
So in the past 6 weeks, sober Sal, 29-year-old, has been running out early, missing scheduled appointments, and unable to reach via phone. Today, he quickly visited to see if he could get a refill sent to the pharmacy. Sober Sal is a Tier 4 patient, which means he gets monthly RX for Suboxone. He's been in the MAP program for 6 months. The SUD case manager agrees to meet with the patient after he has submitted a urine drug screen. The urine drug screen is positive for amphetamine, buprenorphine, meth, THC. Patient reports his new job is stressful and doesn't allow him to keep appointments. He states his girlfriend in early recovery also, who was just released from prison and started using meth again. He is concerned for her recovery because they are living together. Patient states his cell phone was stolen. I can't keep up with all these changes, and you guys expect me to come in at times that I cannot make it. Do you want to ask those questions, or do you want?
Yeah, you can ask them, and then we'll just, people can just start diving in and see how they would handle that situation or those circumstances.
Okay. Number 1, how does the SUD case manager partner with the patient?
You can either answer in chat, or you can get on your mic and speak to it.
I'll share. This is Brenda. Partnering up with the patient, especially in this situation, they're working and they're telling you that their job is stressful and they come in at the times you want them. You have to ask them, like, what times work best for you? That way you don't miss work and feel too stressed out. Because having appointments throughout your workday, as we know, we're working. And if we have appointments, we're going to feel stressed out. And if they don't have the coping mechanisms that they need to not go back to using, that's the first thing that they're going to use in order to not feel stressed.
Good answer. And also, thank you, Brenda. And also, Dwayne from Family Health Center says partner by exploring what patient would like to work on. Miss Yvette, I'm sorry. collaborate as a team and remind them that they are also advocates of themselves. That's a good point. Thank you, Ms. Hubbard. Anyone else? Ms. Scott, you can go to the next question if you want.
Okay, how does the SUD case manager discuss intensifying care by moving from phase 3, tier 4 back to phase 1, tier 2 without it feeling punitive?
And I should clarify, you know, every program has a little bit different of tiers or phases. Like Dominique's program, I think there's 3 phases. And then our program at the Santa Cruz County, we have 5 tiers. And so everybody's a little different. I just try to put equivalent to what me and Dom had, but your program might look a little something different. For example, like ours, if they made it to a 1-month script, it means they've been with us for about 6 months, and all their UDSs have been negative and they've been doing pretty good. And so this question is, you know, how do you discuss maybe possibly moving that patient back a phase or a tier or whatever that is looks like at your clinic without feeling like you're punishing them? Or what would you do? Like if this, you know, you have the whole scenario, what would you do with this scenario, with this?
I don't mind sharing again. I'm going through this right now with a client.
Come on, Brenda.
Sitting down with them and having a real conversation. You know, you're supposed to be negative for everything, but because of whatever reason, unfortunately, from going on a month prescription, we're going to have to give you day by day. So you're going to have to come in, and luckily our clinic opens at 6:30. So somebody will be here to work with you on your working hours. You just need to provide a schedule so we can work with you again. And once you show that you are able to go back to a 1 month or monthly prescriptions, then you know what, that's what we'll do. But for now, based on the program requirements, this is what the necessary steps are in order to support you a little bit.
Beautiful.
And when Brenda, when you're talking about that, I didn't catch, you said Valley Health, is that in Salinas?
Yes.
Okay, so is that that's a methadone clinic, huh? Or
yes.
Or are they doing Suboxone too?
We do Suboxone, and I can't ever pronounce this word. It's the ESL and me buprenorphine.
Buprenorphine, yeah.
Yeah, there you go, buprenorphine. Yeah.
Okay. And so when you're saying they would come back to maybe daily, that would be on methadone?
Daily dosing, yeah, here at the clinic with our nurses.
Mm-hmm. I think I'm gonna speak to my experience a little bit. So I think without any kind of structure or just real in-touch relationship with our patients with SUD and OUD, I think we'll find them in a lost state. And I think what I talked about on the last webinar we had was just our relationships with the patients. And I think when we establish things, my case manager, my nurse, we establish it's not actually, I don't want to say expectations, because how can we have expectations in these great, things for people who are struggling? So as far as our contract goes, it talks about it, explains to them what happens if this happens. If this happens, this happens. So when patients do things and they're in a different phase and they have to come back, I never really had a tough time with it, because it's their decision to put themselves in these type of situations. And I think it's our job, well, my job, I'm not gonna say our, because I don't know how other clinics work, to keep them in a structured in some kind of way, because they're living in chaos as it is. So you have to be somewhere to give them a foundation to be truthful with themselves and to be honest and understand that things there's a give and take to things. And I think patients really understand when we have these open relationships with them.
Yeah, that's a really good point, Dom. When you were saying that, this one, two things came up for me. Structure is important, and Brenda just put that in there. Structure is needed through any step in recovery.
Right.
Sometimes I think we can lose that balance. Some people will take harm reduction to a certain extent, and we can lose that balance of having any form of structure. There needs to be some form of accountability, and it doesn't mean it has to be punishment. And then the other part goes with this. You know, I once heard my buddy who also works in the field. He always says, you know, don't just make this a transaction. Make this a connection, right? And so really, like, how are you working with them, talking with them? I think the other thing, you know, being very clear when you do an intake or however that is at your clinic, these are the guidelines of the program, you know, and this is what happens when this happens or this happens or this happens, you know, and everybody kind of agrees to that, because that's what Dom was saying. They sign a contract. We also have a treatment agreement that we have everybody we go over in the beginning and sign. And so they kind of know or what's expected, you know, and it doesn't make it so hard. I see Margarita put revisiting goals. I think that's also important too, because sometimes we or our patients can lose focus of what those goals are, right? When challenging situations are coming, like, sounds like this guy was doing really great for 6 months, and then he had a lot of stuff that started to go around him that made him maybe slip up, you know.
And also at 6 months, at 6 months, a patient should have new goals. There should be new goals at 6 months. If a patient has gotten that far through the program, there should be a whole new set of goals going into the 6 months, I think, you know. And I just want to mention something else, because, you know, I like this discussion we're having. Harm reduction. We talk about harm reduction, and I think we follow the harm reduction as okay, it's okay, it's okay, it's okay, it's okay. But when is it not okay? When do things become not okay? When do things become like, if I'm guiding you to harm reduction and nothing's changing, I need to look at what I'm doing, because we do play a part in their harm reduction guidance. So I think we need to always be aware of that too.
So I wanted to jump in here because I would say that since I live in a rural community and through COVID, and we've had several patients who are off of opiates but remain on meth for years in our program. And when somebody does suddenly relapse on meth, it isn't necessarily like we're taking you all the way back. Let's, you know, like, it's more like we kind of do come at it from a harm reduction, like, what's happening, what can we do to help support you? I think that for our providers, I think when it's alcohol or benzos or something that actually adds danger, if they've relapsed on opiates on top of the buprenorphine, or they're switching back and forth, then it becomes we're more concerned for overdose or their health. Whereas with meth, we're not necessarily concerned with that as much. I mean, if you look at the data, there's been a huge increase in meth overdoses, but I think we do actually work with patients who would relapse on meth. We would work with them more in a harm reduction way than a punitive way, or any kind of necessarily, like, previous to COVID, we used to keep them on a 1-week script if they were continued to use meth. And we had people come in for 2 years, 1 time a week, because they weren't going to drop the meth, and they don't use it. They use it like coffee almost, you know, it's like, it's not causing them problems. They're working, they're doing these things. We don't want them to use, but we've tried like 50 ways to help them, and they just don't want to quit at some point, but they are not using opiates. So we have kind of gone into that where, you know, the opiate was the biggest concern of overdose. So we just continued to treat them and talk to them and see how, use motivational interviewing on methamphetamine use.
Well, I want to go ahead. Okay, well, I want to say, like, when we're talking about this patient, this doesn't apply to every patient that say would probably relapse. It can go case by case with us at this organization. But what you're saying is absolutely right. We do, like you brought them back to 1 week. That's the structure. Bringing them back to 1 week. And during COVID, things change and you can't do that. But I mean, when COVID hit, us in Marin, our program never changed. The only thing changed, we didn't have in-person group no more. Our patients used to come in weekly. Every week we would see our patients through COVID. Nothing never stopped. Only we couldn't have groups because we couldn't all be together. But we continue the same process. And when patients done this, we'd have conversations with them. And if it continues, like probably go back a phase. We need to see you a little more, just like you're talking about, Susan. I think it's no more you can do than that, probably. Go ahead.
Yeah, we do have patients who struggle with transportation, and we don't have, like, we're not a big city with buses everywhere. We have people who there's no way to get anywhere. Even, if they can't get in, then, so, and during COVID, they shut the transportation down too.
Right.
So, but, we just work with people and try and do the best we can.
Okay.
One of the things that I personally feel like has worked for me is not just in the MAP program, but in other forms of recovery, is building the relationship and the trust through empathy and transparency. When I'm able to be, to show my empathy through, our own personal struggles, as well as, being transparent with what I expect from them and what the program expects from them, stepping a patient down back to weekly is, I think, part of the harm reduction thing as a whole, right? It's like, so we can keep them accountable, keep closer tabs on them, keep them from, and remind them that it's for their safety. It's not a punishment. It's something that we do to just kind of keep a closer eye. And that way, when I've had that trust, they're like, oh, okay, that makes sense. Like, I get it. And they don't feel so punished, if that makes sense.
Yeah.
That makes absolute
sense. May I ask a question?
Yeah.
Okay, my name is Glenna, and the reason I didn't answer your question when you called on me was because I was getting a phone call from one of our patients who missed his appointment, wants to know when he can come in and get a prescription. And my question is, how do you walk the tightrope of their emergency and not taking it on as your own emergency, and yet knowing that if you can't squeeze them in for the provider's schedule, which is bulging, that they're going to go without their Suboxone. So the patient created the emergency by missing his appointment last week, but now he needs his Suboxone.
So, I mean, I think everybody can kind of chime in. Our clinic's a little different. The county clinics, how we do things. If that usually happens, we have backup providers, and we usually have the patient, if there's no appointment available with the doctor, we have them meet with our drug and alcohol counselor. Our drug and alcohol counselor will have them drug tested because the doctor will want to see that point of care and possibly send out, depending on what's going on. We'll check in with them, do a one-on-one. See what happened, how things can improve on this, and all that, and then we'll get them back on schedule. We'll send a note to our provider and say, hey, this is what's going on with them. Check out my note, and can you give this person enough medication to get them to, and like Dom said, it's case by case, right? So it might be different for somebody else. It might be that this person is a chronic person who comes and does this every week, or every couple weeks. Might give them enough to get to our net. We have shared medical appointments, and so we might say today's Wednesday, and the next shared medical appointment that he normally goes to is on Tuesday night. Our provider will give him enough Suboxone to last Tuesday night, and then he'll see the provider and he'll get back on track. Or we'll do the ring around a little bit, and then we'll have different discussions with that patient. But like I said, it's case by case. It could be like we've had patients that are done great for years, and something happens. Life happens to all of us, and something happens. Maybe dad died, car broke down or whatnot, and it's legit. We won't even do it. Maybe that person's been with us for years and they're getting a 3-month script. we probably will still do the 3-month script. Maybe we'll just do a bridge for a month until they come back in, you know, and then the provider will see them again and then give them back to their 3-month script. So like I said, it really just depends on the patient. We have a workflow for patients that it doesn't really happen like that, where they're missing their appointments and all that stuff, and then patients that rarely happen.
Yeah,
But
well, thank you. Because I feel like, oh no, it's a crisis. And then I remember, wait a minute, it's the patient that got this situation set up. And it's ironic because Sober Sal is almost the case history of this patient. And I think, whoa, this is pretty impressive. But thank you for those ideas, because maybe the solution doesn't even need to look exactly like a regular flow of things, but we can do some accommodations just to get him back into a flow. And maybe at this point he's working and he has had a special relationship. So he was coming in monthly for his drug testing, but only seeing the provider every other month. And now he's missed that appointment. So we may need to redo that.
Mm-hmm. I see everybody has a bridge program, so that's good. So that's the same thing we do. My practitioner, my nurse has the DA licenses of my providers. So if a patient comes in, okay, so everything is done on Friday in our clinic. Everything is done on Friday. It's a culture of our clinic, of our program. Our patients know that Fridays, but if a patient misses an appointment, what we'll do is we'll give him something. First, we'll schedule him for the next appointment. My nurse will, like for Monday. So he'll get enough to last until the days till his appointment. And then he'll see the practitioner, give us a urine drug screen, and we'll move him on. But the chronic ones, as Danny say, we work with them a little differently. They may have a time where we have a patient that just continues to do this. So how do we work with that patient? We work with that patient to where they just come in every 3 days and we'll have it ready for them. But the good part about it is they're coming in. They're coming in. So it's not an inconvenience to us because we're here in the office all day. So it doesn't really make a difference if they want to come in to give us a UDS every 2 or 3 days, you know. So I think with working with MAT programs in primary care, I think there's so many moving pieces. And like I see a lot of people have CHWs and a lot of people don't have CHWs. The CHWs are so influential to a MAT program. SUD counselors and health workers are sort of, because they're the bridge to the provider. You guys are the bridge, and I think it's important for your relationship with each patient is so important. So I think you guys are doing great, man. You know, and I'm glad that we're being really interactive when we're talking because there may be people on here that don't really understand how it's done yet. There are new clinics coming in, and we're the ones who can like give them some kind of pathway. So thank you all for being here, sharing, and giving your opinions. It really makes a difference. Thank you.
Yeah, thank you. Another thing I wanted to say is that Don touched on is, you know, what if you do have that difficult patient, the chronic patient that comes in every week that says, I can't be there. You set up everything for them. You bend over backwards, you take care of everything, and they don't come Friday when you have it set up. You know, what do you do? You know, the other piece of us having those other difficult conversations is that, okay, I got a little message right there. We also have in Santa Cruz, at least in Santa Cruz, not in Watsonville, but in Santa Cruz, we have Dominican Hospital. They have the ED bridge. So if there's an issue and a patient can't get to us for whatever reason, and they missed all their appointments and we were not able to bridge them for whatever reason, they can go to Dominican and withdrawals, and through the ED bridge, they will give them a script if there's a MAT provider there, or they will give them a dose of Suboxone enough to get them through for 3 days. So they would have to go, and it's been different with COVID. I think they've had people that have actually wrote the script, but they could do 3 days, and they usually contact us like, hey, so-and-so, your patient showed up over here. We gave them enough to get to you, and then we get them scheduled back in and try to get them back into wherever that slot is, you know? So I think that's another good resource if you in your community or where you're located, if they have an ED bridge, that can help out as well too, you know. And we also have an after hours line that we have ex-waiver providers are there if there is issues. Sometimes, you know, might not be so key to this situation, but sometimes we have situations where the prescription, it was Friday. Last week we had it happen, matter of fact. Friday, almost 5 o'clock, patient got a script and everybody's gone after 5. They went to the pharmacy. The pharmacy said they never got it. Patient didn't get their Suboxone, so they had to call the after hours line, and the after hours line had to follow through with the pharmacy, so the patient could get or did not get it. You know, sometimes that happens too. But at least when we find out if it didn't happen, we try to work out those kinks with our after hours line or with the pharmacy. Sometimes that stuff happens. So looks like we got about 20 minutes left, maybe less. Anybody else? I'm going to read the last few questions, and then anybody else want to jump in, anything else that they have or situation, how they would handle that different at their clinic or whatnot. So what are the interventional needs of this patient? How does the SUD case manager discuss the methamphetamine use? How does the SUD case manager support the therapeutic alliance between the provider who is new to treating OUD and the patient? So maybe you have a new provider that this patient is presenting to, and are there any safety concerns? What are they, or are there any safety concerns? And remember, he was doing great for 6 months. His girlfriend just got out of prison and she started using meth, you know. So what else is going on there? What other conversations can you have with them there?
Brenda, again, I think it was Dominique who mentioned having open conversations. And if it wasn't you, I'm sorry, I can't remember who mentioned that, but having the open communication with your client and asking, like, you were doing great, I know you're working, girlfriend, what's your structure like? What's really going on? I'm here to help you. This is your program, make it fit to your needs. And at the end of the day, we have to educate our clients on how Suboxone and Bupe affect them while they're using illicit drugs, because there can be adverse effects. So we have to educate them. And if our clients really don't know, then that's our time to like at least plant a seed in their head so they can at least think about it. Maybe not take action right then and there, but the seed is still there. So that is a good thing. And then just checking in on them, revising their goals. And again, we use contingency management with our youth, and that has been working. So if contingency management is something that'll possibly work for this client, then, you know, you have to try all your different outlets before, I don't want to say give up or give out like no more hope, but you have to try everything. Otherwise, in my case, how would I feel as a case manager if I just give up because the client isn't doing anything that he's wanting to do?
Exactly.
Thank you, Brenda.
And
how else would you handle that? Anybody else?
One thing that I notice is that he says that his girlfriend is in early recovery and he is concerned for her recovery. And then he lost his cell phone and then he can't keep up with the appointments. And so it's our fault. Somehow he is looking outside of himself for all these things that are his basically his excuses. So how can we, and I don't ask the question because I know the answer, I'm asking the question that because I need some perspective, but how can we help him to refocus on the answers for himself, not about his girlfriend in recovery, not about his can't keep up with the appointments. You made the appointment, so what can we do to help him take responsibility for his own stuff, not everything else?
This is Dominique. I really don't think that the answers lie within him. You know, I mean, like, how did you get to this place, Mr. Sal? How did you get here? What happened? Where'd you go wrong? I think these are all the questions you need to find out and have him do the search. He'd have to search himself out to find out. His girlfriend's in early recovery, but he relapsed on amphetamine, methamphetamine, and THC. So there's some disconnect there. She's in recovery, but he's doing other things. So it's so many dynamics to this, to what's going on with Sober Sal. He lost his phone. How did that happen, Sober Sal? For 6 months, we were able to contact you and you lost your phone. What happened? You know, it's all about what happened. How did you get there? You know, I think that's important. And if you know, when we, most of the time when I work with patients and you know, it's like my big thing is restoring humanity. My big thing is about making them feel that they are worth, the world needs them. We need you. You don't need me. I need you. I need you so we can figure this out together. So if I don't have you helping me figure it out, then it's like we're gonna go around and round in circles. And Brenda said something about a patient, right? I think we work in primary care. So there's never an end to our patients. There's never an end. In our program, we've had patients that cycle through, I can say 30, 40 times. It's medical care. It's not a substance use program. So we can't find a way to like let them go or something. I think out of 6 years and out of 600 patients, I've had to discharge one patient. And that's because he called my nurse every name under the sun. And I told him like, that's not appropriate. What you should write a letter and apologize. And he refused to do all that. So that's the reason why that patient can't come back to our program, but he can get medical care in our clinic. So there's no end to our patients in primary care. I don't think there's ever an end. I think they just stop coming, you know, and we're here to catch them when they come back. So
yeah. Anybody else have anything else on that? I wanted to say, and thank you, Dom, and everybody, Brenda and everybody. I feel like we're like the mirror, you know, we're just kind of mirroring back to the patient for them to see, you know, we're facilitating that process, whether it's in a group or a one-on-one, for them to see their own responsibility or their own place in that, you know what I mean? It's not us like telling them, hey, you're doing this, or you're doing that wrong, blah, 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 blah. You know, nobody wants to really hear any of that. And so it's a really fine dance, I think, when you're doing a one-on-one with a patient and, you know, holding that mirror up so they can hold themselves accountable, right? Because it's up to them, right? And I think as you're doing that dance through the motivational interviewing and refocusing on those goals, or what their goals are, like that can start to transform those conversations and make a really good connection, you know? You know, when I'm looking at this, I'm thinking, okay, cool, we can get you another phone somehow. They got what do they call them, Trump chips now or whatever. They used to be Obama phones. I don't know what they are. Biden phones, you know, the free cell phones. Here, we can get you a phone. There's one right here underneath the bridge. Let's go get you got your ID. Let's go take care of that right now, you know? Okay, so your phone's taken care of. What are some other things that we can do? You know, oh, you were doing great for 6 months. What happened with girlfriend came out, she started using meth and you slipped up with her. You know, how do we get back to where you were at, you know, and looking at all those things. And also, you know, someone said praising Margarita, praising them for their appointment, but praising them also for, look, you had 6 months. Shoot, you don't be down on yourself. You know, you're beating yourself up. That's a trigger for relapse too. You can't just keep beating yourself up. You know, and maybe this is, somebody just put that too, Brenda, right? Maybe it's not a relapse. Maybe this is just a slip up, you know, a little lapse. You know, I just gave in with my girlfriend. You know, what do I need to do? You know, asking them, what do you need to do to set up some healthy boundaries with your relationship with your girlfriend? You know, and then also that goes back to the punitive thing. You know, not being punitive. Maybe we do pull you back for a little bit, and we check on you weekly for a couple of weeks, and we agree to like, okay, we add this contingency management. My program does have contingency management too, and we can pull that in and say, hey, you know what? Why don't you come in and give me a couple negative drug screens, and we'll check in on how everything's going, what things are going with your girlfriend, you know, work, all that, setting up some time. You know, maybe you need to put a schedule together. Maybe that'll help you out. You know, you can show them. Some of our patients don't know how to use the computer good, and they have their phones. That Google Calendar is pretty cool. You show somebody how to do it, they can work a wonder for them. Dollar Tree, I don't know, everybody got Dollar Tree. Dollar Tree, they got calendars too. They could write down their appointments. I've had patients where we go to Dollar Tree and we buy a bunch of those calendars. They're only $1, the little pocket ones, and they keep their appointments in there so they can remember when to come or call or whatnot. So I mean, there's a lot of different ways, and we can all do different things and methods in this. So and it really depends on what you as the counselor or the what is it, community health worker or whatnot, but also the procedures and stuff that you have at your clinic. And like I said, I think the main thing is not letting it just be a transaction, let it be a connection, you know, make sure you're really connecting with that patient and refocusing those goals. I don't think we have a lot more time, so I don't want to keep going over this, but can we click to the next one? Does anybody else have any last words on this? Maricela, re-engage patient, assist with updating his triggers and relapse prevention plan. Yes, educating with lapse and relapse. That was Brenda. Okay, cool. So we have a contingency management question, and the answer might not be on there. We just put it on there just to start a conversation. But what we're gonna do is, if you want to click to the next slide real quick, and then we'll go back one. We're just gonna give out, whoever gets the right answer, we're gonna give out one of these shirts. So you're gonna have to shoot me your information, and I'll mail it out as soon as I get them all set up. You want to go back to the question? So if I get a volunteer to read it, and then let's see what whoever wants to go first and say what they would do.
Mr. Moore, would you read that?
Yeah, Kim calls her Matt SUD case manager to report that her 14-day supply was stolen from her unlocked car this past Saturday night. Reports she hasn't had any buprenorphine or naloxone in more than 24 hours. Requesting an early refill. What procedures does the SUD counselor follow in the care of this patient? A, tell the patient tough luck. You'll have to wait till you're due for the next refill. B, tell the patient how you could have left your, B, tell the patient how could you have left your door unlocked and tell them this is their fault and that there is nothing else you can do. C, tell patient you need to speak to the doctor. I can't help with that situation. It's beyond my scope of practice. D, assess patient situation and circumstances and then assist patient in filing a police report. If they are not able to do that on their own, you can file a police report most of the time online and get a copy of your prescriber or to your prescriber so the prescriber can get the patient a prescription.
Who wants to take a stab at that? Remember, it doesn't have to be on those multiple choice. It could be something else.
I think everybody got you in the chat, Danny.
Man, how we're gonna have to give out too many shirts.
That's all right. Susan D, Margarita D.
So it looked like Yvette or Ivette, if I'm saying that wrong, sorry. It was the first one to put an answer in there. So if you want to give me a mailing address and put it in there, that is correct. At least that's what we would do at our clinic. It could look a little different at each clinic. So I don't know if anybody wants to chime in on that. Dom, if you want to say something.
No, I mean, if any other facilities, what would be your process in this? Because I could learn something.
Me or
no,
anybody
I'm talking
else?
to anybody
Okay.
else. Yeah.
For us, we would do D, but you know, if this was a repeat offense and they were losing their medication like once a month, or the medication kept getting stolen, which we did just have a patient that this happened. We actually had her therapist work with her on like, how do you change your behaviors? Like, you can't leave your medicine in an unlocked car. How can you leave your medicine at home, or, you know, a lockbox? Trying to work with trying to figure that out, and then, you know, try and figure out how to change the fact that it keeps getting stolen, because at some point the provider will say no, and it is up to a provider whether they're going to keep replacing it, and a pharmacy won't, your insurance won't necessarily pay for it. So that's the other issue. I always try and remind them, you know, you're going to have to pay for it yourself now, and that's why it's important for you to lock it up or keep it safe.
Just come to think of it, we had a patient like this continually. And what we did, but it was really happening to this patient. They were homeless and their camp would get raided and stuff like that. So We had the conversation with the patient about Sublocade. And he was like, yeah, like, okay, you can't get it now. So that's one time it worked for us, real easy, is talking about Sublocade. So those are conversations that we should be having. I think we should all be having with our patients too, the Sublocade. So we got,
looks like we got 5 minutes. I've had this happen numerous times at our clinic, and most of the time, like, you know, as long as we usually check in with the patient and assess whatever it is, it could be someone that's, like I said, chronic, or it could be a one-time thing. And usually the providers trust us to write the script, but then it hits the pharmacy, right? And the pharmacy might say, nah, man, we can't do this. We can't build insurance again. They're going to want them to pay, or do you have a police report? And so sometimes that has happened where you know, the patient had to file a police report and give it to us. Sometimes some patients are not able to do that, so they might come in here and we'll do a one-on-one, and we'll walk them through the process on the computer here and do that, just so we have all our bases covered. I try every time whenever I'm doing patient care, especially for the provider, I try to take everything off the provider's plate that I can, that they don't need to do. That way everything's set up for them to do whatever they need to do, you know? So if that's me helping the patient get the police report or figuring out all the details of all that, I get all that information, and then I pretty much give that to the provider, and then we go from there. But you know, it could be different for each clinic how that goes. But I think the main thing is the insurance is not going to want to give them another script or pay for another script for that same time period. And they might not even ask for the police report. It's just better just to have it. I feel like covering all your bases, just have it just in case they do ask for it, you know? Okay, we got 5 minutes. I think Juan wanted to chime in. Is there anything else that anybody else had before we close today?
what I want to say is thank you all. I really enjoyed this hour with you guys today. We got more forums coming up, which will get more intense. But thank you guys for all your expert opinions and advice. We appreciate it. Thank you.
Great. So is that all you have to share, Danny and Dominique? Is it okay for me to wrap up?
Yes.